Hi guys, thank you so much for joining us today for our PanAmerican Hemodynamics webinar and Neonatal Hemodynamics Research Center webinar. We are very excited for the speaker and panelists that we have for you today, along with our excellent moderators. Just a couple of housekeeping things. Please remember to follow us on Twitter at NeoHemodynamics. Also, you can hashtag the NHT ACE special interest group. And any questions, please put them in the Q&A rather than the chat box. We will be looking at the Q&A, and any questions that we are unable to answer, we will post them onto our Twitter page. And I will put the link to the Twitter page as well as the link to the YouTube page where you can watch the video after the session is done. Thank you.
All right, should I take it away? So thank you so much, everyone, for joining today. I'll be one of the moderator with Dr. Amish Jain today. So I'll be introducing our panelists and then our speaker for today. So first off, as one of the panelists, we'll have Dr. Bischoff, who is graduated from medical school at the Federal University of Rio Grande do Sul in her hometown in South Brazil. She completed her pediatric residency at the Hospital de Clínicas de Porto Alegre, and she pursued her neonatal perinatal training at the University of Toronto at the Hospital for Sick Children, where she grew a special interest in the field of neonatal hemodynamics and targeted neonatal echo. Her research interests include cardiovascular physiology after definitive PDA closure and the use of cardiac magnetic resonance. And then we'll have Dr. Friedberg as another panelist who's a staff as a pediatric cardiologist at the Hospital for Sick Children since 2006. He's also a professor of pediatrics at the University of Toronto and a senior associate scientist with the Sick Kids Research Institute. He is also a director of the research in the Echo Lab at the Hospital for Sick Children. He has established an independent CIHR-funded basic science lab that uses animal and in vitro models to delineate the mechanisms of RV dysfunction and ventricular-ventricular interaction. And to complete our panel, we have Dr. Savoia, who's a consultant neonatologist at Santa Maria de la Misericordia Hospital. She completed her neonatal specialty training in the UK, and she further developed her interest in neonatology performer echo with Professor Evans in Sydney and in neonatal pulmonary hypertension with Professor Edmond in Denver. She has a master's degree in pediatric cardiology from Bologna University and is a member of the ESPR government structure on NP. She's also the lead on the first edition of the Italian training program in neonatology perform echo. And it's my pleasure to introduce our speaker for today, who's been up since very early in the morning. It's 4 a.m. For him right now. So thank you very much for joining us today. So this is Professor Sehgal, who's a neonatologist and the head of cardiovascular research at the Monash Children's Hospital. He's been there for the past 13 years. He's completed his PhD in 2016, and his research was recently awarded the Australian and New Zealand Neonatology Network Emerge Respiratory Research Award. He's a member of the award selection committee at the American Academy of Pediatrics and has conducted and chaired invited hemodynamic sessions at the Pediatric Academic Society's annual meeting. His current research focuses on cardiovascular adaptation in infants with severe bronchopulmonary dysplasia and those with fetal growth restriction. So thank you, take it away, and thank you so much for being here.
Well, good afternoon, good morning, good evening, everyone, depending on which part of the world you're in. I'm just hoping I'm audible and my slides are visible. Yeah, if somebody could say yes to that.
It looks great.
Okay, okay, fantastic. I'll keep my video off for the duration of the talk. So thank you for the invitation, Patrick, and the team. It's a delight to be linking up with like-minded people who are interested in hemodynamics, and surely we can learn from each other. So today I would be talking about an aspect of severe BPD, which has received less attention. That's the broad outline of my talk today. Talk about contemporary opinions around chronic pulmonary hypertension. What's the evidence behind the cardiac lung disease? This is a term I guess is coined by Patrick, just like a few other terms he has coined. How does it transition to combined pre and post-capillary pulmonary hypertension? Some brief evidence from neonatal animal models. What's the role of bedside echocardiography, and just 1 or 2 slides about how catheterization could be useful. And I'll end with systemic hypertension, and the focus conventionally is pulmonary hypertension, but what's the prevalence, relevance, how do we manage, and why is it important for these cohorts going forward during childhood, adulthood, and what's the significance there? So the consensus definition of BPD differs in different parts of the world. In Australia and New Zealand, we don't go into mild, moderate, severe. The definition from the Australian-New Zealand neonatal network is the lung disease ongoing requirement for oxygen and ventilatory support 36 weeks, while the Americans, of course, have distinguished between mild, moderate, and severe. It's important to understand it's a heterogeneous disease. There are contributions from the lung parenchyma for which you need tweaking for the ventilatory support, volume guarantee, high frequency, gent ventilation, you name it. The pulmonary arterial component, where the pulmonary arterial vasodilators come into play, like nitric oxide, prostacyclin, and sildenafil. And then the pulmonary venous component, which is what we would be focusing on today. So it's important to understand this specific phenotype because it has connotations for prognostication as well as choosing what's the appropriate therapeutic intervention. So BPD, as we know, is the most common long-term respiratory sequelae of prematurity, a high incidence in premature infants, especially at the extremes of prematurity. In many centers, including ours, routine echo screening is done from 34 weeks onwards, and you look at the literature, there is a variable incidence or where you can pick up presence of pulmonary hypertension in these cohorts. Now, just showing some recent work from colleagues overseas looking at pulmonary hypertension associated with BPD. Many of the papers you see, they use subjective parameters like RV dilatation, RA dilatation. Others have used more objective echo parameters, looking at the incidence. In our cohort, in severe BPD infants, it was about 39%. So how do these patients present? They present with increasing respiratory support or labile oxygenation. And conventionally, we look for features like RV hypertrophy, dysfunction, increased PVR. And that is where the assessment and management is focused on, is to reduce the PVR, thereby increasing blood flow to the lungs using pulmonary vasodilators like nitric oxide and sildenafil. That's the conventional thinking. But when you look at the horizon or what other people are looking at in other cohorts, LV diastolic dysfunction is an important component in this pathophysiology, and European guidelines also separately categorize for chronic lung diseases and especially for the lung issues arising from the left heart, the systolic and diastolic dysfunction. So it's important to understand this paradigm shift, that what's the focus or what's the relationship of changes arising from the left cardiac or systemic arterial changes like the aorta, and how does it influence or color the pathogenesis and diagnosis and especially treatment in a subset of infants with BPD. Now, scientifically, if you look at the chain of anatomical connections, it is plausible. If there is chronic systemic artery hypertension, then it can generate a lot of systemic afterload, or this disease might arise from the heart itself, where there is LV hypertrophy, LV dysfunction. It can lead to increased diastolic end diastolic pressure in the left heart, left atria, causing pulmonary venous hypertension and become an edemogenic factor. So this sequential contribution, which arises from the systemic circulation or the left heart itself, that's termed as the post-capillary pathophysiology, or you could call it the cardiac lung disease. And the current therapeutic strategies, where you reduce the PVR and try to flood the lungs with blood, that may be counterproductive, because the problem is mainly blood not able to get out efficiently from the lungs. So you will see this figure frequently in my talk. This is what we're talking about. The focus currently is on the blue segment, the left bottom side of the heart, where we preferentially go for pulmonary artery vasodilators to increase the blood circulation to the lungs. While what we are talking about is disease either originating in the left ventricle or originating really in the aorta, where there is increased aortic thickness, stiffness, and that is transmitted to the left ventricle, where the LV function is compromised, that pressure is generated and passed on to the left atria. And these are a range of echo parameters I've listed from our 2016 publication, which could be useful in delineating this particular part of pathophysiology, where along with assessment of the systemic vasculature, you look at LV contractility and function, and then you look at what's happening across the mitral valve and across the pulmonary venous circulation in the form of lower pulmonary venous flow or stroke volume across the mitral valve, or measures like transmitral EA Dopplers, isovolumic relaxation time, and end systolic wall stress. So these are the measures which would give you the information. Many times when we ask this question to our own cardiologists, they really go with the idea that, okay, the RV is not dilated. We're not seeing too much tricuspid regurg. They don't particularly focus on the left heart, and certainly they don't do measurements which are listed on this particular figure. So it's part of ongoing collaboration with cardiology. And since 2 years back, it's part of routine assessments we do, assessing the left heart as well in infants with severe BPD. This is a photo from, I think, Satyen, and I just draw the attention of the audience to the right bottom panel. This is what we're talking about, where the LV is dilated and dysfunctional, and the septum is, instead of being pushed into the LV, is actually being pushed into the RV. The high pressure is generated, passed on to the LA. So you can see the PFO is left to right. Compared to the right upper panel, where it's a conventional pulmonary hypertension, where the septum is actually deviated to the left ventricle, and the shunting of the PFO, if it is there, it's actually right to left. So these are simple measures which should be picked up in any echocardiogram which is being done for infants with severe PPD. Now, how common it is, evidence from adult literature, you can see that more than 60% patients, if they have LV systolic dysfunction, and higher if there is diastolic dysfunction, they could have pulmonary hypertension in association to the left heart disease. And that's not limited to structural heart disease, but also non-structural conditions like systemic hypertension could be the things which could generate this high back pressure into the LA, cause transudation of fluid across the pulmonary capillary beds, which can lead to poor compliance and prolonged need for respiratory support in our cohorts. So the issues could be from the aorta, from the LV, from the mitral valve, from the aortic valve. Anything which is after the lungs could be implicated. Now, as I mentioned, standard pulmonary vasodilator therapies could be problematic. And if you look at adult studies in which they have been able to diagnose this particular component, especially secondary to mitral valve disease, so those cohorts have been excluded from trials where they are evaluating pulmonary vasodilator therapies, because they noticed that in these cohorts, unexplained, there was increased morbidity and mortality. And that again stresses the importance that when we look at lung disease and we look at the heart, we also should look at what is happening on the left side before we start pulmonary vasodilator therapies. Now, neonatal animal models, they may be useful. Limited data is available to improve our understanding in terms of pathophysiology, how the disease progresses, what are the therapeutic targets. And in this paradigm, the developing porcine model, which uses a non-restrictive PV banding at a younger age, which gradually becomes restrictive as the animal matures, that's aided a lot of our understanding. Now, we know that pulmonary hypertension and hypoxia, so there is a lot of effect on the right side of the heart, but it's also known that chronic hypoxia in the rat model decreases the cross-sectional area of the left ventricle, and that can affect LV function and then influence LA dynamics. So important to understand that hypoxia doesn't selectively affect the lungs on the right side of the heart, but there are implications to the left side of the heart as well, and that feeds into what discussion we're having. Many a times in the neonatal population, you can see BPD may also be accompanied by a similar pathophysiology of pulmonary vein stenosis. So the bottom line is wherever the pressure is arising from, whether it's due to PV stenosis, whether it's due to the problems in the mitral valve, whether it's because of LV dysfunction, or whether it's arising from the systemic aorta, the effects are pretty much the same, that initially it results in passive pulmonary hypertension or the post-capillary pulmonary hypertension. And over time, if it's not diagnosed or not treated appropriately, then it becomes transitions into a combination of pre and post capillary pulmonary hypertension as the disease progresses. And the consequences, as I mentioned before, ultimately you would see higher pulmonary venous pressures, resistance, pulmonary arterial pressure, and vascular remodeling, which happens throughout the vasculature. Very briefly, it's important when we do this understanding of the role of the left heart that we appreciate there is always LV-RV crosstalk. And conventionally, as I mentioned earlier, when the RV pressures are high, the septum is displaced into the LV. But in this case, things are a bit different. And the reason why the crosstalk between the two ventricles is important, because the epicardial myofibers on the right and left side are contiguous, and the subendocardial fibers are also oriented in a peculiar way in which there is a lot of interaction between the two ventricles. So for a simple echocardiography assessment, the septal configuration, the motion, whether it's a conventional motion or is it a paradoxical motion of the septum, and also the eccentricity index. So those could give you some clues about how the two ventricles are interacting with each other. So moving away a little bit from pathophysiology, what regulates in terms of modulators? So it's important that we have a healthy endothelium, and there has to be a balance between vasodilators and vasoconstrictors on the systemic side. And this balance in this particular pathophysiology is altered. So there is increased angiotensin II, there is increased endothelin-mediated vasoconstriction and lower vasodilator influence of the nitric oxide pathway, and some role of calcium channels as well. So endothelial dysfunction and vascular remodeling are two main pathways which are affected. And the reason I talk about this is because that directly feeds into how we treat this pathophysiology. So angiotensin I gets converted to angiotensin and then activates the receptors, and there is prevention of RV remodeling in rats. So that's the broad ACE2 counter-regulatory enzyme pathway. And during chronic hypoxia, which is common in these cohorts of experimental models as well as human infants, ACE is upregulated, so a lot of angiotensin II is produced, while ACE2, which is the counter-regulatory enzyme, that's downregulated. So the combination of this imbalance leads to a pro-inflammatory pulmonary vascular remodeling effect, and correction of this imbalance has therapeutic relevance. So I'll talk a little bit about that close to the end of my talk. We started looking at this particular issue around 2015-16 because there was a series of cases where for severe BPD infants, pulmonary vasodilators were used, especially nitric oxide, and there was a deterioration in those patients for unexplained reasons. And once you look at the cardiac anatomy and where the pathology could be coming from, and after deterioration, the echocardiograms were reviewed, there was an indication that perhaps the disease is not originating from the lungs to start with. I think there is an issue on the left side of the heart. So since that time, we started monitoring these infants very closely, and we see that in severe BPD infants, we pick up this left side pathology in at least about 3 in 10. So that's the prevalence in our unit. But if you look at, and we don't do cardiac catheterization here, we look at echocardiography. So it's possible we are underestimating the disease here as well. So that's something to collect more data on to see how this literature evolves. So this particular study looked at prospective echocardiography study, looking at the systemic afterload and pulmonary venous back pressure changes, looking at them as pathophysiologic factors. And we analyzed infants, 20 preterm infants who had severe BPD. And then we had preterm infants with no BPD, and they were compared with healthy term infants. So we're talking about assessments of the systemic vasculature here. So we looked at the systemic artery side and also the cardiac function side. We noticed a lot of impairment in diastolic measures in the BPD group, and those measurements persisted after adjusting for gestation age and birth weight. Now, a range of parameters we made assessments on. Some were focused the conventional, the right side of the heart, the pulmonary hemodynamic characteristics, the right heart function, and then the systolic heart function in terms of fractional shortening and mean velocity of circumferential fiber shortening and parameters of diastolic function. I think all these parameters are very familiar to the group I'm talking about, so I don't want to go into the detail there. But if you look at this group of infants, so BPD group is the first column, then the preterm infants with no BPD, followed by the term infants, healthy term infants, and unadjusted effect, gestation age adjusted effect, and birth weight, and combined gestation and birth weight adjusted effect. You can see these parameters are significantly different and impaired in the infants with severe BPD group. Now, in this group, we didn't particularly look at mild or moderate BPD groups, but that's a topic for another discussion where lower severity of BPD also has some element of compromise. But looking at this tip of the iceberg, if you please, then there are significant impairments which allude to the fact that it's the left side of the heart could be of interest. Now, clinically, how do they present? They present with an unremitting clinical course. There's lack of response to diuretics, no improvement or deterioration when you start pulmonary vasodilators. That could raise the suspicion that there is either pulmonary venous stenosis, the issue, or there is LV function disease, which is coming from the left side of the heart. And as I mentioned, a range of echo parameters are useful, including the left ventricular tie index, the transmitral ratios, the tissue Doppler velocities. So they could be helpful. Now, of course, there's a difference between how PV stenosis or LV dysfunction could present. So again, these are two key parameters where you could see interatrial shunting and end diastolic LA pressure. They could be the ones which distinguish whether this pathology arose from the left ventricle or this pulmonary venous stenosis, something which needs to be looked at. So echocardiography certainly remains the initial modality of choice. It is more physiological, done real time. You don't particularly need to sedate the baby. You don't particularly need to intubate the baby for that. But catheterization, of course, is less physiological because of the anesthesia effect as well. But certainly it adds more detail and adds much more value and might influence management outcomes. We don't have cardiac cath in our institution, but I know a lot of American institutions, that's something which is easily available and accessible. So this study in 2007 was done to look at how the pulmonary vasculature is reacting to a challenge, and the challenge conventionally is nitric oxide or 100% oxygen. So you would expect infants with pulmonary hypertension would have a positive response. So in this group of 13 infants, there were 7 infants in whom, after nitric oxide was given, the pulmonary capillary wedge pressure actually showed a significant increase. So it's possible, one of the reasons why this could be happening is, the pulmonary capacitance is altered, or possibly this is the cohort we are looking at, that the issue is the problem in the left heart compliance or diastolic dysfunction. So catheterization could give you some clues around that as well. So as I mentioned, long-term administration of drugs like sildenafil, again, physiologically difficult to justify, and also might cause clinical deterioration. So how does it affect my practice? As I said, we look at these infants through echocardiography. This is our paper from a few years back. We did similar pulmonary circulation reactivity testing using nitric oxide and 100% oxygen. These are all infants born less than 28 weeks, assessments made 36 weeks post-menstrual age, and a range of echo parameters I spoke about earlier, looking at the cardiac contractility on the right side, the left side, the pulmonary vascular resistance indices, and also the parameters affecting the left side. So what we were looking for, a percentage change in parameters in response to these interventions. So we collect the baseline data, then we expose the infants to oxygen 100% for 30 minutes, re-echo them, then return to baseline, and then 3 hours gap, we challenge them with nitric oxide for half an hour, then make assessments and gradually wean the nitric oxide. This is how we did this. And what we found was that there was a population which had a non-reactive component of pulmonary circulation. And if that is the case, in response to this challenge, that it might suggest the dominant pathology is coming from the left side rather than the right side. And that is what we use to rationalize treatment decisions going forward. Looking at the hypertension issue, so there is the left-sided literature is very limited. As I mentioned, it's limited to appraisal of systemic hypertension. And previous studies have looked at different parameters, how they define hypertension. One study looked at systolic BP of more than 130, others looked at a mean BP of 105. So they, in present day and age, these numbers look very high. And 2017, American Academy of Pediatrics laid out some guidelines about 50th, 95th, and 99th centile according to blood pressure, systolic and mean and diastolic according to gestation ages. So for 36 weeks, the 99th centile is actually 95 millimeter mercury. And for the mean BP, the 99th centile is 72 millimeter mercury. So these numbers on your screen, they look way odd from what we look at in the current. So a couple of papers, one from us and one I think from the Iowa group as well. We looked at infants, preterm infants with severe BPD at 36 weeks compared with double the number of infants with no BPD. And you can see on the right side panel, this is a 7-day average from 36.0 to 36.6 weeks. Both the average systolic BPs and the mean BP was significantly higher in the severe BPD cohort. So the 7-day average is high, and also a lot of infants during that week had recordings of a 95th or 99th centile or higher. So amongst BPD infants, within the group of BPD infants, if they were hypertensive, that was also associated with a longer duration of respiratory support requirement within the cohort of BPD. So as I mentioned earlier, this hypertension on the systemic side via back pressure changes can be, and the edemagenic factor we keep talking about, lower the pulmonary compliance and greater need for respiratory support. So that was highlighted in this study within the cohort of BPD. Now, of course, hypertension is an important assessment, but if you go back a little bit to where this is coming from, then you could see that systemic arteries in these infants are quite thick and stiff. So this study, which we published Journal of Perinatology, compared 3 groups. One is column 1 is severe BPD infants, then preterm no BPD infants, then compared with healthy term infants, and data adjusted for gestation age separately with birth weight, and also combined. As you can see, the aorta intima media thickness is significantly higher, and the impedance stiffness index and vascular resistance is much higher, and the pulsatile diameter, that is how much is the motion on M mode between a systolic wave coming and going, is significantly lower in the severe BPD group. So it's important to appreciate that systemic hypertension could be easy to assess by the bedside, but there is more under the radar which we don't particularly understand. That's the problem in the systemic arteries, and there are reasons why systemic arteries are thick and stiff through chronic inflammation, oxidative stress, increased collagen, decreased elastin production, and all that ultimately feeds into increased afterload, poor myocardial contractility of the left heart, and increasing LA pressure, the pulmonary venous congestion. So we have been working on this model since 2015, looking at various aspects of heart function as well as what's happening in the aorta. Now, coming to the therapeutics, there are case reports. The initial case report of 2 infants was from Peach Marani, and I'll just talk a little bit about that, some of our own work, and then some work which I've noticed from Adrianne and Patrick and Regan's work more recently. So this is the 2008 work where they looked at 2 infants with severe BPD who had LV diastolic dysfunction. And findings were subtle, confirmed by cardiac cath, and recognition of this aspect was quite delayed in the disease process, and they were unresponsive to diuretics, and both experienced significant hemodynamic and clinical improvement with systemic afterload reduction in the form of ACE inhibition by enalapril. We looked at this cohort more recently. These were unresponsive to standard therapy, had systemic hypertension, and we just wanted to see whether ACE inhibition is physiologically useful in these cohorts. So this is the broad description. You can see all were extremely preterm infants, less than 1 kilo, all of them. They had been on sildenafil and diuretics. And for every infant, the first column is their baseline respiratory support, and we gave them ACE inhibition for a period of 5 weeks, made reassessments, clinical and echocardiographic assessments, and you can see all these infants had significant improvement in their respiratory support parameters going forward, and we were able to discharge them home on low flow or a combination of high flow, low flow therapy once we finished the 5-week therapy for ACE inhibition. So these infants go home on captopril therapy, and we monitor them sequentially for a period of 2 years. So they were not responsive to conventional therapy like diuretics. There was no improvement on sildenafil, and addition of captopril, that's our go-to drug here, led to significant decrease in oxygen requirement and systolic BP, which was clearly above 99th percentile, stabilized between 50 and 95th centile at repeat assessments. We also monitored these infants through echocardiography, and this is a range of echo parameters we looked at. And what we found that over a period of time, the echo parameters, there was less thickness and increased pulsatility. So a more compliant aorta was noticed. On the left side of the heart, better contractility, better relaxation, decreased elements of end-diastolic LA pressure. And although the medicine doesn't act on the right side, but the effects of easing the pressure on the left side were found to be on the right side as well. So better cardiac output on the right side and decreased pulmonary vascular resistance. This is work from Patrick's group. So neonatal hypertension in BPD, looked at 11 infants, all extremely low birth weight, preterm infants, and on non-invasive respiratory support. Enalapril again started quite late, either delayed manifestation or a delayed recognition. And that's what I really want to stress, that we need to start looking at this population when we start doing screening echoes for BPD in these babies, maybe 34 weeks onwards. And all these infants, you can see they improved within 2 weeks of treatment with ACE inhibition and improvement in diastolic function indices. And importantly, 4 of these infants had been on amlodipine, and there was no improvement on LV diastolic dysfunction. So something indicates that ACE inhibitors have something special, may have a superior treatment profile in the setting of LV dysfunction. And perhaps the reason is that angiotensin 2 is front and center in all that which is happening. So it affects free radical formation, it stimulates more release of norepinephrine, aldosterone release, endothelial dysfunction, and that's perhaps the reason why ACE inhibition seems to be physiologically and therapeutically more suited compared to other antihypertensives. It tends to reset the balance between vasoconstrictors, proliferators, especially angiotensin 2, and the vasodilators on the other side of bradykinin, nitric oxide, and prostacyclin in the vascular wall. As I mentioned, angiotensin 2 has a role to play in endothelial function abnormalities. And if you look at this data from 296 adult patients compared with calcium channel blockers, beta blockers, diuretic inhibitors, all were equally effective in reducing the BP, but it's only the ACE inhibitors which improved endothelial function and endothelial dependent vasodilatation, as Patrick's work has noticed, in response to ACE inhibitors is when you actually see improvement in LV dysfunction. Again, this is another group of studies in combination of animal data and human data, is that in contrast to beta blockers, which did not affect vascular structure, because ACE inhibitors are the ones which inhibit arterial smooth muscle hypertrophy and inhibition of the replacement of the elastin fibers by collagen fibers. Important to note, collagen fibers are more than 100 times stiffer than elastin, and ACE inhibitors are the ones which act on the reversal of remodeling, if you want to put it that way, and show efficacy in improvement in LV dysfunction. So it seems ACE inhibitors are physiologically very suited to in this particular subset of infants with BPD, once you get the BPD pathophysiology of LV dysfunction right on your assessments. So take home message from me is that assessment of LV function is important, and also the systemic vasculature is important in infants with severe BPD, especially if there are persistent radiological features where you see there is pulmonary edema despite you giving diuretic therapy, or if this edema or the clinical picture worsens in response to your conventional pulmonary vasodilators. So such physiology-driven approach is needed, because they may not be responsive, counterproductive in terms of your standard therapy. Recent data also shows that preterm infants, as they grow up in children, young adults, and adulthood, they have higher incidence of ischemic heart disease, hypertension, heart failure. And again, it's possible we are in a good position to make these assessments while infants are with us in the first year of life, and it's possible physiological driven therapy could be an important modulator for cardiac disease going forward. You do the rounds every day. Don't walk away when you see the blood pressure in the severe BPD infants is high. If that is persistent, then it's important to not ignore that. Appreciate that there is a pathology which could be originating from the left side. And so it's biologically plausible, as I mentioned, that you are in a position to not only make improvements in the clinical setup in the short term, but also something to as a positive effect on cardiovascular health in children, in childhood and beyond. Now, that is where I want to end. There is a short 2-minute video, if I can show. I just want to see whether that video still works. And then I'd be happy to take questions.
We'd like to invite our panelists and moderators back on.
Lauren, can you hear the audio behind this video?
Arvind, you need to click the unmute on the video itself on the right corner. There's a little X.
So pitifully small and sick Baby born at a mere
How about
23
now?
weeks has miraculously survived thanks to an Australian first drug intervention. The tiny girl wasn't expected to live, but doctors at Monash Children's Hospital have told Emily Rice they're surprised and elated by her recovery.
When little Shifra was born at just 23 weeks, she was so pitifully small and sick. Her parents, Michelle and Neville, were told her chance of survival was slim.
I had so many doctors coming in to tell me the outcomes would be very, very poor. She'd be blind, she'd be deaf.
Delivered in August last year, she was suffering chronic lung disease and her fragile body weighed a mere 513 grams.
She could fit into my ring.
But we kept praying. I kept praying.
Medical staff rarely resuscitate babies born so early, but experts at the Monash Children's Hospital Neonatal Intensive Care Unit took a chance.
A lot of us actually had given up hope, but the family stayed strong and we thought we'll try.
Her doctor tried an Australian-first treatment. He gave the struggling infant a drug normally prescribed for high blood pressure to hopefully help her lung function.
But I told them, let's go for it. Let's give her everything, whatever we can.
We decided to give this a go, and fortunately it worked for her.
She improved, getting bigger and better by the day, and last month was well enough to celebrate her first birthday in the ward.
Happy birthday to you.
Shifra has grown from around half a kilo when she was born to now almost 8 kilograms in weight. Now, after spending her first year of life in hospital, this bouncing baby has headed home.
Now she can talk to me. She tells me off. She makes sounds. She coos. Dada. Dada.
While still needing breathing support, developmentally she's healthy. And her parents, both nurses in Melbourne, say hospital staff have inspired them to always hold on to hope.
It's amazing. It's really amazing.
It's an amazing team and they don't give up.
Emily Rice, 9 News.
Well, a Dutch treat for those who...
So look, I'm sure all of us have come across stories like these. It's very rewarding for us to see the work of the team appreciated, and this was the first baby we used captopril on, and as disease process would have it, we had written a do not resuscitate order for this child that evening before my team asked me to do an echocardiogram on this baby, and this is the first baby which we picked up with the significant LV pathology. And we started her on captopril, and it was a turnaround like nobody even dreamt about. This is talk about 2015, 2016. She went home on a combination of high flow, low flow. 3 months later, her mom called us in panic that she doesn't want any of the prongs in her nose. She never looked back. So within 3 months, she was off all respiratory support and came off captopril at the end of 1 year. And has not looked back. So we're continuously following this baby up, and she's a 6-year-old, neurologically normal, developmentally normal baby with no respiratory support ongoing required. So very rewarding intervention for us, and it goes to show that physiology is always true. So happy to take questions for this presentation. Thank you.
Thank you, Arvind. That was an excellent presentation. Thank you so much for sort of laying it out for all of us, the various potential contributors to pulmonary hypertension. So I'll invite the panelists to actually switch on their cameras again. So we are hoping to have a little bit of a lively discussion. Doesn't have to be only Arvind, sort of mixture of all of us who are in the panelist. I think I'll start by asking one thing to everybody actually, and we'll be appreciated if everybody can weigh in on this. I mean, it's easy. This is my own personal experience. I find it easier to try something new when our back's up against the wall and nothing else is working, and then it leaves us with a proof of concept that in certain patients this really works. And then my challenge after that becomes, how do I find the patients who are not that sick early, where an experimental therapy, which is experimental in the sense that we don't exactly know about it, can be tried early enough. And that has happened to me in multiple different domains when something really works, and then we try it a couple more times and then it doesn't work at all in those patients, and then we just left in between. So do you have any suggestions in terms of LV? How do you identify clinically significant LV pathology in these particular kids?
Yeah, thanks, Amish. So we have, it took us some time to convince cardiology people to come on board. We were able to demonstrate a series of cases where this pathology was in play and the medications worked. So 2021 onwards, we have a set protocol which includes assessment of the left heart and the range of echo parameters I mentioned. So typically, if on a 4-chamber view, they see the septum being deviated into the right side, so LV is more dilated than the right side. And if a PFO is present, that's shunting left to right. So, and the baby is in the clinical profile I mentioned, that's generally the initial ticker for them to say, okay, we need to open that table which Arvind and cardiologists together have created. So I'm talking about the echo text now, and do all those parameters we talk about. And any baby who gets started on this particular therapy, it's not a decision we make easily. We sit together with the clinician, with the cardiologist, and look at all the echo parameters to say, okay, this seems to be the dominant pathology here. We need to start this rather than go towards sildenafil or see sildenafil and go towards this. So it's an individual decision we make for every baby. And as I mentioned, we are picking this up in about 3 in 10 babies since we started looking at, in more detail.
So just to confirm from my own knowledge, LV dilatation and a PFO shunting left to right, I mean, it makes sense. Those combination is what sort of tips you in towards LV pathology.
So that's for the echo text when they come and do that echo. When I'm doing this echo, then I look at all the comprehensive parameters to start with. So I don't particularly set myself only with these two, but these are the parameters which are very easy to pick up without going into, tissue Doppler measurements and all. This would give you an early clue. Even if other parameters are normal and you look at these two things at 34 weeks, if you repeat this echo at 36 weeks, many a times you would see that a lot of parameters which were on the normal side or on the edge now have become abnormal. So it's something which we sequentially need to follow these babies up alongside, of course, what's happening on the clinical front.
Okay, thank you. Do other panelists want to weigh in on that in terms of perhaps Mark or Marilena?
Right, if I may add something. In our unit, we do perform the lung ultrasound as well, together with the echocardiography, functional echocardiography. So when we suspect that we are dealing with the post-capillary pathophysiology, we would look very carefully to the lungs as well, because if we have a back pressure, it means that the lungs get quite wet as well. There's some interstitial water there, and the lung ultrasound can pick it up quite well. We would put the lung ultrasound features in the picture, and of course we wouldn't use only the lung ultrasound info. We would add the lung ultrasound info to the echocardiography and the clinical data.
That's an expanding field for sure. We're still figuring out how best to utilize it in our care. Mark, would you like to add the cardiology perspective in this?
Yeah, I don't know if the cardiology perspective or my perspective, but firstly, thank you very much, Dr. Sehgal, for an excellent talk. And I think for highlighting the left heart and what we always consider right heart disease. And just to maybe expand beyond, there are many relevant topics here, because in congenital diaphragmatic hernia, it's well known, the lack of development of left-sided structures in size and maybe in function as well, and other conditions. And it's really a tough topic, and it's one the adults struggle with the whole time. The whole notion of heart failure with preserved ejection fraction is essentially what you're talking about, or a form of it. And I think even in pediatric cardiology, we really struggle with that notion in lesions such as coarctation, where you repair the coarctation, but there's abnormal systemic vascular resistance, perhaps persistently, that affects the left heart. So it's really complex. But I think for the pathophysiology, and before I get to the echo, I had more questions than answers, let's say, because I wasn't sure if in the infants you're seeing, for instance, if you have systemic hypertension, are the left-sided changes more acute responses to those loading, or are you talking more about chronic changes that are happening because of abnormal vasculature, and abnormally stiff vessels chronically? So that would be one question. And then a second treatment question, angiotensin 2, you put at the heart of the pathophysiology. So I think one question I would have angiotensin receptor blockers, which are used clinically very commonly in adults, and we use them as well, and in heart failure as well. Have they been effective? And we've done some animal work to show that they may reverse the fibrosis that you were talking about, or at least prevent it in rat models of pulmonary hypertension. And there's been some work for pulmonary vein stenosis as well at sick kids by Chris Calderon and other researchers when he was here. So it might have effects on those as well. So those are just kind of general comments. I also had Amish, and I won't take up all the time, but I think part of the complexity of this talk is exactly the right-left interactions that you were talking about, because if you start with BPD and pulmonary hypertension, and then you have a component of left-sided disease, you have interactions in both directions as you speak, and then it becomes quite complex to know what's happening. But echocardiographically, I would also, I might question whether left ventricular dilatation as acute versus chronic. So when we see chronic systemic hypertension, you can get a more globular LV, a more globular looking LV, but you would also see hypertrophy, which may not make for measurements of a dilated chamber. And I think it's important to look at the atrium as you spoke about. So if we have a primary pulmonary hypertension picture, and you can measure a TR jet velocity, and you've got a dilated right atrium, and as you said, with PFO going right to left, and compression of the left atrium, you've got a predominantly right-sided picture and interaction. But if you've got a high TR jet, or you've got a picture of pulmonary hypertension, or you've got invasive pressures, and then you've got a midline septum, you've got a systemic blood pressure measured, and you've got a PFO either bidirectional or left-sided, as you were saying, I think that's quite, you should look further. And as a pediatric cardiologist, I would also stress that you should look for congenital heart disease, left-sided congenital heart disease, to exclude that in that setting, coarctation of the aorta, aortic valve stenosis, and any left-sided obstructive lesions. So those are just some of my comments to begin with.
Thank you, Mark. Audrey?
Thank you. Just looking at the questions and commenting on what you actually just brought up, Dr. Friedberg. Maybe Dr. Bischoff, I might address this question to you, and you can start. And how do you manage this kind of disease from the RV and LV disease in these patients, so that you might be using sildenafil on a patient that has post-capillary pulmonary hypertension? So sildenafil might actually worsen this patient. So how do you manage that kind of RV disease and use a sildenafil, and then LV disease where you might actually be using more of an ACE inhibitor? So if you want to comment on that.
Thanks, Audrey, and thanks, Dr. Sehgal, for the wonderful talk. I think one of the challenges that we have run frequently is that although we like to put these patients into very clear buckets of right heart or left heart, there's a lot of patients that actually have mixed disease. There's a couple of them where it's very clear that they have a predominant phenotype on one or the other, and we can treat it that way and see if things improve. We've had one patient recently that we were treating very aggressively with right heart type of management with sildenafil and other pulmonary vasodilators. And when we sent the baby to the cath lab, we felt that the left heart phenotype was more predominant. So we weaned that baby rather quickly from the right-sided therapies and put that baby on enalapril, and she actually deteriorated, which meant that in the end, she needed a combination of both type of therapies at the same time. So again, just to echo what other speakers have said, it's very individualized how we treat these type of patients. Our frequent approach is to start with diuretics because that can treat either side of disease, and sometimes you don't need any additional therapies. And then we try to guess based on the echo what is the most predominant phenotype, and we use one therapy first and then add another one later. Along those lines, though, I will say that sildenafil will also drop your afterload to some extent from a systemic vascular resistance, and therefore I don't necessarily think that sildenafil may make them too worse. I would say that direct pulmonary vasodilators such as inhaled nitric or inhaled epoprostenol are more likely to be harmful than the ones that have both systemic and pulmonary effects. So we've had success with babies on a combination of these therapies, and I think it's very individualized. I know that's kind of a wishy-washy response, but that's unfortunately how these babies behave.
That's our life these days, wishy-washy in most things. Thank you.
Just a couple of comments to Mark's questions or comments. So in hypertensive babies, LV hypertrophy and cerebral vascular accidents are known if there is acute hypertension for some reason. So the cohort we're talking about is more like a chronic. If you start following these babies from 33, 34 weeks onwards, you will see that parameters gradually evolve over time. So ACE inhibitors themselves versus angiotensin receptor blockers. So the former, so there's not huge amount of data available, but what goes for ACE inhibitors is their effect on improving endothelial function, changing vascular remodeling or reversing vascular remodeling. They also increase the production of prostaglandin E2s. So that results in vasodilatation and reduction in afterload. So it's a very peculiar group of drugs, which not only it has more than afterload reduction, dynamic afterload reduction properties. In addition to that, it also has some effects on the architecture of the vessel wall and beyond that. So perhaps that's one reason why a lot of information on cardiac lung disease, whether in the animal model or in the adults, is focusing on ACE inhibition in preference to, the other antihypertensive. So it's just more than simple afterload reduction by other medications. There are some questions in the chat box. I can.
Yeah, you want to address that one? There are actually a lot of questions in the audience. I'm not sure we will be able to address all of them, but we'll try. And there's a lot of interest in the ACE inhibitor aspect of it. So I'll sort of try to club these and see Arvind and Mark and perhaps Patrick and everybody else who's used ACE inhibitors. To be honest, I haven't used them much in pulmonary hypertension kids yet. So I think one question is. Yeah, go on.
Sorry, one question, the one which has just arrived. I think I was expecting that question about the hesitation of nephrologists. So yes, so you look at this cohort of babies we use, so they are all 38, 40 weeks plus infants. So you're absolutely right that 38, 40 weeks onwards, we are more comfortable and confident in using this drug. And the dosage we use at is much lower as compared to a lot of other people would be using. And it's important that we keep monitoring renal functions, renal Dopplers, and the cardiac function and clinical parameters, how they evolve. But yes, we don't use it in extreme preterm infants. They're all 38, 40 weeks plus babies.
Amish, can I just make just a couple of comments? I have a question, a very specific question for Mark. So I think that we have obviously monitor these babies very, very carefully. I think everything you've heard, this is not a simple thing. This is not a very common thing either. You know, this isolated left heart phenotype, it probably exists, but not necessarily kind of incredibly commonly. But I think the bigger concern we have is the cognizant neglect of hypertension that exists in neonatology. You know, most of the time the blood pressure is high, the nurse keeps measuring it until she gets a normal value, and then it never gets airtime, kind of in many NICUs. But the question I have for you, Mark, is a very specific question. So we have learned from work from Adam Lewandowski and Kara Goss that our preterm babies are growing up to be adults with cardiovascular maldevelopment, both left and right heart, and also systemic hypertension. So we now are seeing this entity, which, as you described correctly, looks like the HFpEF, it looks like diastolic heart failure with preserved ejection fraction. And we have drawn a potential association between hypertension and diastolic dysfunction as if it might be causal. But I don't necessarily know if it is causal. You know, are there any ways we can figure out with echo whether, you know, the disease we're seeing is really just left heart disease, a diastolic impairment from poor development, and they just happen to be hypertensive, or the hypertension is causal? Can echo help us differentiate that part of the equation? Because it's very complex.
Yeah, well, it definitely can be causal. So, but in the individual patient, you're asking, is it associated, or you think it's the cause? I mean, you know, I don't know in these premature infants in response to, you know, Arvind's answer to my question, but I would say if there's LV hypertrophy, right? If you have, you know, we don't always have Z scores at the lower end of the range, but if you have those, if there's LV hypertrophy and you have a globular looking LV, certainly, but you don't need it. It certainly can be causal, and then the echo would help you with that. And if in the presence of pulmonary hypertension, I think you would then, what I was saying before, you know, you would see where the septal position is, what the atrial shunt is, and where the atrial septum lies. By the way, it's not only the premature infants that are manifesting later in life as adults with, you know, left heart disease and abnormalities. If you have IUGR as a fetus, even if you're born, you know, term, etc., those babies have abnormalities that persist into childhood and into adult life. Some of them are subtle and we don't know what the meaning of those is yet, but they are different versus controls, at least in studies. So this is an issue. So echocardiographically also, you know, to the group, I think assessment of diastolic dysfunction is extremely challenging. I don't know how to diagnose it, quite honestly, and you know, that's maybe a whole other lecture and discussion, but it's extremely challenging. And I think the more smaller you get, the more difficult it becomes. But I would think if you have left atrial enlargement, and we've discussed this before, I think, Patrick, so I think the left atrial parameters are important. If you see, you know, signs of increased filling pressures, which to me would not be E over E prime. To me, it might be more important to look at pulmonary venous A wave reversal, left atrial distension. As I said, if you don't have microregurgitation, you know, and it depends on the pulmonary hypertension and how distended your right atrium is. So it's complex to put it all together. But even in children, we don't have the answers. So I think it's complex.
May I just add one thing to that and sort of get everybody's thought on that? One of the things, if you review the echo literature in chronic pulmonary hypertension in BPD kids, when we look at that almost everywhere, including our own data, we find that majority of kids who have diagnosis of chronic pulmonary hypertension with a flat septum is what the most commonly used thingy. Majority of them still have a left to right atrial shunt. So it is different than the acute pulmonary hypertension literature, which has always confused me why these patients have a left to right shunt despite having high right-sided pressure. And I know it's a compliance game, but could that give an idea of whether how much LV is contributing?
Well, it's exactly what you said. It's a compliance issue. So, and it's complex over the cardiac cycle, and it's complex over the respiratory effects of the filling and then the ventricular interaction in terms of that. So you could get a bidirectional, or as you say, even right to left, because it is dependent on the diastolic compliance of the ventricle, let alone the atrium.
So in the presence of a chronic pulmonary hypertension, if we have an exclusive left to right shunt, is it fair to say the RV compliance is better than LV compliance? Would that give an idea towards LV pathology at all? Or is that something you see in pediatric also?
Well, I can let others chime in with their experience, but you see it in pediatrics. But if you have a truly high atrial pressures, because ultimately it's the pressure difference, but the pressure difference is generated by the compliance difference, just like pulmonary vascular resistance or systemic vascular resistance driving blood pressure or pulmonary arterial pressure. But it changes, of course, over the cardiac cycle. But I think you can, we've never done a study, and I'm not familiar of the actual ratio, Amish, to your question, LV versus RV compliance based on that. But I don't know if it reassures you, you know what I'm saying? But I think if you have pulmonary hypertension and you have just a left to right shunt, you should at least look for those other things. And just one other comment, the adults, at least on a research, I don't know that this is widespread in all labs in the world, but they're using strain imaging in HFpEF because, the preserved ejection fraction doesn't tell you about the systolic function necessarily. That's why it's HFpEF and not just normal systolic function. And strain is usually reduced in those patients. And the higher the blood pressure or the resistance and the worse the myocardium, the more reduced it's going to be. And then you'll get stuff like post-systolic shortening and stuff like that.
Mark, I'm sorry for we're pestering you now, but I've got to ask you one other question. So again, we've searched the literature for standardized definitions, scores, whatever we can for diastolic function in the adult world, and there's really nothing out there. But the one thing for the small number of patients that seem to fit into this phenotype with hypertension, as you described, they consistently do seem to have a very dilated left heart, some are hypertrophic, A-wave reversal, long IVRT. The one measurement that never adds up into this is the ET prime. It never seems to be consistent with everything else.
Yeah,
and it helps us to, because you see it in the literature, and it just, I don't know.
This is my opinion, Patrick. So take it as that, not as a guideline or anything. I don't think the E to E prime reflects filling pressures. It certainly doesn't correlate well with filling pressures. I'm not even sure it does so in adults, Sheriff Negaya's work, which was seminal, and it does correlate with outcomes in a lot of situations. And what I think is happening is that it's any ratio augments the abnormal parameter of that ratio, right? If you just have to take E prime alone, you're not so sure if it's that, but once you ratio it, you're augmenting the abnormality, in my opinion, in the E prime, and that's the one thing. Even in adults, it was shown early on that the E to E prime ratio will only correlate with pressures if it does correlate if you have delayed relaxation. And at least in children, and I'm not sure about these infants with the BPD or the left-sided disease, if you have delayed relaxation or not, because in children, we don't commonly see delayed relaxation. In fact, we only see it overtly in children with overt hypertrophic cardiomyopathy. So it may not work in that situation. So yes, in research studies, we always report it because the reviewers are going to want it because it's an established measure. It's in our echo reports. I don't think it's a measure of filling pressures. I'd much prefer to see atrial enlargement than E to E prime. And how to define diastolic dysfunction? Well, that's a Pandora's box. But I will tell you, there was a really interesting study from adults 30 years ago in aortic stenosis, and again, adults, okay, where everything does fit a bit nicer into these boxes. When they had pure aortic stenosis, if the hypertrophy correlated with a long IVRT, whereas filling pressures and diastole, correlated with, let's say, atrial enlargement and with maybe the severity of the pressure loading. And so there's different components of what's driving each of these measures in early and late diastole. So the pressure loading, by the way, just in itself, if you acutely afterload a heart, the delayed relaxation is going to happen. And then eventually, you're also going to increase filling pressures, but the degree of hypertrophy is going to affect your things like the isovolemic relaxation time.
Audrey, I'm going to be Amish for the last few minutes because he's run away. Okay, I want to ask a question to Marilena. So, obviously you have a lot of expertise in lung ultrasound. Okay, and obviously, I think one of the messages for the audience today is that hypertension is not something you should ignore in neonatology. We need to pay attention to it. There may be consequences, and some of our respiratory therapies could cause harm in those patients. But how can lung ultrasound synergistically help us interpret this left heart phenotype better? Are there specific things that it can tell us that may give us more guidance that actually, yes, this looks like a very pressure-loaded left atrium pulmonary venous circulation? And has anyone published on that?
Right. As I said before, the post-capillary phenotype causes an increase in interstitial water, lung interstitial water. The lung ultrasound can pick it up very easily. So what you can do is not to diagnose the left ventricle diastolic dysfunction directly from the lung ultrasound, but you can look at the lung and see the consequences of the left ventricular diastolic dysfunction, the water. You can hypothesize that that water that you see with the lung ultrasound is due to the left ventricle. You can treat the left ventricle dysfunction and see what happens in the lung. And if the lung clears, if the water goes away, it means that you did something to improve the clearing of that water. It means the left ventricle diastolic function. There's no more pulmonary, how can I say, backup pressure. And this is one thing you can observe. Another thing we are working on is to see if there is any correlation between lung ultrasound score, which is a measure of lung involvement, and measures of diastolic dysfunction. And what we found, we are looking at those babies now at 36 weeks, but we are working early and at earlier stages and later. What we found, it was that those babies that had signs, that had, let's say, measures of diastolic dysfunction, such as IVRT, such as E prime and A index, and those who had worse measures, worse of these variables, they had worse lung ultrasound score, not only. And those babies were those with severe BPD and some of those with moderate BPD. Moreover, we tried to see if there was a correlation between those variables and lung ultrasound score, and we found a correlation within, between IVRT and lung ultrasound score, E prime, and a certain degree between T index and lung ultrasound score. We had a look because we do follow those babies from birth to the first year of life. And we are working on those time points, birth, 14 days of life, at 36 weeks, of course, 4 months and 8 months. And what we are seeing is that the correlation is kept mainly, I would say only, between IVRT and lung ultrasound. This is at 14, since this happens since 14 days of life, not at birth. So in my opinion, yes, the lung ultrasound can help a lot to interpret the post-capillary pathophysiology, but it would be only one of those tools you can use to diagnose the post-capillary pathophysiology. I don't know if I explained what I intended to say.
Yeah, that makes sense. I think we have time maybe for one last question, and I wanted to talk to Dr. Sehgal and Adrianne, who actually you both mentioned it in your talk and in your answer, Adrianne. What's the place of the cath in these patients? We've talked about limitations of diastolic dysfunction with the echo. When do you send these babies to cath?
I'll let Arvind go first.
We don't have cardiac cath facility at our institution. If we have to send somebody, it has to be across the city, so we don't. But we have a good collaborative link with Peds cardiology. We make these assessments when we think they are needed, and we choose the right patient. So, I mean, we simply don't, but I know a lot of American centers do. I mentioned a little bit about the acute vasoreactivity testing, and that is done in the US by cath monitoring. We do it in echo monitoring using the same protocol of nitric and oxygen challenge, and we've got good results with that. So there could be an odd baby who would benefit from that, but we don't have the facilities to do that, so we don't. But yeah.
Here we have a pretty high threshold before sending babies to the cath lab, unlike some other US centers. Our usual practice is to try something empirically based on our echo findings and then send babies to the cath lab if we are still escalating on therapies or if we are not getting the response that we were expecting from a certain treatment strategy. So let's say we thought it was predominantly right heart disease. We started sildenafil, things are still not improving or not improving to the extent that we were expecting. We might go for the cath lab to confirm the findings and measure left-sided pressures as well before adding a second or a third line of medication.
All right, thank you. Patrick, did you have anything else to add, or should we?
You wrap it up, Audrey.
All right. Thank you so much for Professor Sehgal again for joining at this time of the day for you. It was a very interesting talk and we got a lot of questions, and we'll be probably sending away some of these questions that we didn't have time to go through today. And thank you to your panelists and to my co-moderator, Dr. Jain, for joining today. And we hope to see you at the next meeting. Thank you.
Thank you. Bye-bye.
Thank you.